I would like to convince you that rescue intervention for PMTCT should probably include infant prophylaxis, what we call the infant PrEP, in order to achieve MTCT elimination. You probably all know this, famous figure that has been recently updated, showing that despite the extremely effective and interesting rollout of B+ worldwide, there are still some difficulties, and there's only a small group of countries that has been able to achieve elimination of MTCT, HIV MTCT, as defined by UN agencies. And as you can see in this figure, a very big part of the residual transmission that are observed in many countries are related to breastfeeding transmission of HIV. And in my view, any HIV infection that are acquired via breastfeeding is presently unacceptable, as we have existing tools to prevent it. Just to go into a little bit more detail in a real-life situation, these are the results from a real-life situation in Bobo-Dioulasso in Burkina Faso, with the results of the performance of the PMTCT cascade. It was drafted during the second semester of 2015, but I can tell you that the figures are exactly the same. I had access to them some days ago in the year 2016 and early 2017. And what you can see on this is that the performance of the cascade is fairly good, with most women having access to HIV testing. Most HIV infected, 96% indeed, of HIV infected women initiating antiretrovirals. But when we look at the efficacy of the PMTCT cascade in terms of transmission, there is a sobering transmission rate, early transmission rate at 2 months of almost 6%, and an additional 8% of transmission during breastfeeding in the postnatal period. So there are huge efforts that has been extremely successful in improving the PMTCT cascade, but with still a residual transmission that is far from being negligible. So what are the reasons for this residual HIV transmission during breastfeeding? First, there is probably a large combination of the different factors. Late initiation of maternal ART during pregnancy or breastfeeding. And in many cases, women having not a suppressive, virally suppressive treatment when breastfeeding is initiated. A lack of maternal adherence to ART, especially when it is initiated before or during pregnancy. Incomplete PMTCT cascade, some women having no access at all to antenatal clinic, or if they have no access to HIV testing or no possibilities or willing to ART initiation. As Amy mentioned, there is probably a residual transmission that is due to a cell-associated HIV reservoirs. Presently, we don't know what proportion of transmission is really due to this cell-associated HIV reservoir, probably a small part of it. And there is an important problem that has been addressed during the talks of this morning, which are the primary infections in mothers after PMTCT testing during the end of pregnancy or breastfeeding, and which is associated with a very high risk of breastfeeding transmission. So we have very nice guidelines on the use of antiretrovirals as PrEP from WHO, which clearly stated that we should offer access to PrEP to any population exposed to HIV, having an expected incidence of HIV infection above 3 infections per 100 person years. And in fact, this is exactly the situation with breastfeeding exposed infant. And I cannot see why we should deprive this population and offering this service to other population. We had experience, and one of those studies was the INRS 12174 trial of an extended infant PrEP during the whole duration of breastfeeding, during the entire duration of breastfeeding, which is the study that Amy mentioned. We compared 2 regimens, one with the daily lopinavir/ritonavir and one with daily 3TC, lamivudine, during the 1 year of breastfeeding, and showing that the post-natal transmission rate at 12 months was extremely low in both arms. In intention to treat, 1.4 and 1.5%, but of course, even more in per protocol. And that answers the question of Amy in a certain sense, that when the drug is strictly used, there is really a dramatic, close to zero transmission rate. And the tolerance and safety of those 2 regimens were extremely good. We know also, and that was very nicely summarized by Katrina Waite during the CROI conference and in her paper in JACC some years ago, then when a baby is breastfed by a mother under ART, of course, some drugs are passing in the breast milk, and some drugs are ingested by the baby and can come up to be present in his or her blood. But we know from all those different studies encompassing very different antiretroviral drugs that the concentration of antiretroviral drug that is present in the infant blood is consistently extremely low, and lower than the 10th percentile of the therapeutic concentration of those drugs. That means that there is absolutely no risk, or a very, very minimal risk of overdosage if we combine maternal ART in a breastfed infant and infant PrEP in those infants. So, which PMTCT rescue strategy could we imagine integrating in the package infant PrEP? I think that we should at least focus on HIV-exposed breastfed infants, those whose mother has a detectable HIV viral load. But we know that this detectable HIV viral load is a very frequent event in mothers under ART. And for example, in the Meyer study published in 2016, 31% of women have had at least one sample with a detectable viral load in the first year of breastfeeding. When to start? I think at birth, or I like the first CPI visit at 6 weeks. I will explain you why I think it's a good point, a good starting point for those rescue strategy. Which HIV or ARV drug should be used for infant PrEP? I think that we have some evidence for lamivudine and or the prodrug anthracycline, and certainly with the nevirapine for extended prophylaxis. Which additional intervention, of course, in association with the infant PrEP, we should think about either initiation or reinforcement of maternal ART adherence, and of course take this opportunity to have an early diagnosis and prompt treatment of pediatric HIV. And when to stop, of course, when the exposure ceased after cessation of breastfeeding. In our group, we are committed to presently to two studies that have been very recently launched. One is the Prevenir PEV phase 2B and feasibility trial in Burkina Faso, and the other one is the EPI trial that has been that is funded by EDCTP, and it is starting in Zambia and Burkina Faso. And the intervention is very simple. We focus on the first visit. If we accept the BCG administration in the maternity ward, the first EPI visit at 6 to 8 weeks, because we know that in both countries, in Burkina and Zambia, this is extremely well attended visit with almost 100% of babies of those age group attending with their mother this EPI1 visit. There will be an assessment of the previous PMT-CT cascade performance, an HIV rapid test to at least mothers attending this EPI visit who have an unknown HIV status or a too long lag gap in time before the last testing. And for those infected, a measure of HIV viral load and of HIV DNA in their babies both by a point-of-care test. If the HIV-infected infants, there is an immediate ART. If the mother is unsuppressed with a treatment, we will initiate infant PrEP up to 12 months and maternal ART initiation or adherence support. There are some, using the similar strategies, some long-term perspectives that are, in my view, interesting. The first one is using long-acting antiretroviral drugs, which can certainly facilitate the adherence in the long term to the extended infant PrEP. And the other is the use of passive immune prophylaxis with human monoclonal antibodies, which are also benefit from a long-acting formulation, that could be some interesting alternatives, having almost the same principle as infant PrEP with antiretrovirals. So I hope I have convinced you that there is certainly room for rescue intervention, integrating but not exclusively using infant PrEP. And that most probably maternal ART and B+ are not competing with this strategy, but are completely complementary to this rescue strategy. Thank you very much.
So Paulo is going to take the questions. I want to compliment both of you for great talks, but I want to take the moderator advantage to ask Philippe a question. So Philippe, the trial that you talked about really focused more, it seemed, on acute infection in the mother, where you would give extended infant prophylaxis anyway. So if the argument is that the real argument is that the mother is not taking her drugs, she's not adhering, and that's why she's viremic, what makes you think that if the mother isn't taking her drugs, that she's going to give the drugs to the baby, And the second piece of that is, if she gives the drugs to the baby, does that mean she's even going to less adhere to her drugs?
I think for the first part of the question, I think this is just a question of opportunity. If we have a new entry point for HIV testing in the postpartum period, you will be able to catch up those recently infected mothers and intervene at that point. So I think this is a very important point, especially in very high incidence areas. Regarding the willingness for a woman to take the pills for herself and to give oral suspension to the babies, unfortunately it was not published, but we had a very interesting study that was done by a social scientist, completely independent from our team in West Africa, asking very simple question to a mother: if you want to prevent transmission to your baby, what is the easiest way for you? Is to take the pills for yourself and then prevent transmission by this way, or give a drug on a daily basis to a baby? And the massive response was, I will certainly not forget to give the drug to the baby, but I may forget to take the pills for myself. So I think that, of course, that does not prevent us to reinforce adherence, but that at least indicates that both interventions are not competing.
Yeah, microphone number 3.
Amy, you gave that very nice example of a wonderfully adherent mother, but when she was in a situation where she couldn't get her drugs for whatever reason, and that might be because she's not allowed to go to an unknown clinic because she hasn't got a number or something, or because they've got stockouts. I know they might have got a bit better, but they haven't got that much better. So would you think that that mother would have given that baby nevirapine if she had it? I actually think that mothers that I know of who've got children who've got HIV will give their drugs to their children, whereas they won't give them to themselves necessarily. So I rather agree with Philippe on that one. But to both of you, can you say more about formulations? Because I think the major thing about option A was this wretched liquid with syringes that mothers had to hide under flower pots in order to give it to their children. And there was a dispersible baby tablet made, scored 20, but it never kind of took off because I don't think anyone really took it up. So that's a comment for both of you.
So to the first part of your question, that mom couldn't reach the clinic, so she wouldn't have been getting nevirapine for the baby either.
So she'd had some nevirapine tablets in her back pocket, which she took in case. I'm just thinking of other ways of doing, giving something so they have it as a spare.
So I think that motivates for differentiated models of postpartum care. If you know a mom is migrating, give her treatment and the baby's prophylaxis then if you're going to give it to both of them, for the 4-month period. But if a mom's not reaching a clinic to get her own ART, which is the problem, and that's why the risk of transmission is then there, then she's not going to be getting to that clinic to get anything for her baby in place of that. Formulations, I don't know too much about. I mean, I can just maybe speak to a bit more about maybe some disclosures I should have had in the beginning was that I'm a mom and I breastfed my son for 12 months, and it can be a really major struggle to get medication into young children, and I think we underestimate this, or the risk benefit is so much higher in HIV infected children because it's about survival. But when this is an otherwise well infant, how long is that motivation going to stay there for the mom to fight with her infant every day to get this medication in, and particularly if we haven't got good formulations? And then just to say the motion was oral antiretroviral prophylaxis, so the subcutaneous, injectable, whatever other, it's not part of the debate,
That's right. So Philippe?
Yes, I agree that the formulation is a real problem. What I can tell you is that the use of the syringe and to administer a small volume of suspension in the baby was extremely well accepted and used during the trial. I know that real life is extremely very different from a trial environment, but at least it was doable. We had a very good adherence and very few lost administration in the trial. But I agree that we should probably consider this as an important point in this strategy.
Thank you. Number 3, and then number 2.
Hi, I'm Jackie Hoare. I'm a neuropsychiatrist from the University of Cape Town, and I work at Groote Hospital. We had a look at breastfeeding practices in women in the Drakenstein study, so that's an area in the Western Cape. And we found when comparing women infected with HIV and those non-infected that the infected women were less likely to breastfeed. And I was just wondering, thinking about the behavioral implications of offering a mum PrEP for the baby, yes or no, wondering whether she'd feel more confident to breastfeed if the baby had PrEP versus not. I mean, certainly we know that there are health consequences of not breastfeeding. So I think that would be something really interesting to look at. I also look after adolescents with eating disorders. And one of the things that I'm noticing, and Stunzi's data, is the rise in obesity in adolescents. And we've had a look at some of the feeding records of these adolescents with obesity, and exposure to carbohydrates really early in development has become something that is coming out, certainly not something that I've researched. But I'm currently looking after an adolescent with a BMI of 95 who was exposed to carbohydrates at 3 weeks of age. He weighs 265 kilograms.
Yes, I cannot say more than agreeing that we absolutely need more social science investigation and behavioral evaluation in this context. I agree fully.
Yeah, and I agree with that too, and I think that speaks to the whole realm of really understanding the experience for women, postpartum women living with HIV much better, and investing in that, understanding how they're making decisions, why they're making decisions, and potentially a more targeted approach for women that are really struggling, because a lot of women are actually doing really well. 75% are staying in care and managing to take treatment. So I think we really need to invest more in understanding this complex time of life and understanding how women are making decisions and what's motivating them.
Gareth Chid-Williams from London. Philippe, I was really interested in your ANRS 12174 data. You know, the bit that's missing from that database is the long-term psychological impact on the mother-infant dyad of trying to give that child Kaletra on a daily basis for the first, 12 months of life. Have you got any data at all to show the long-term consequences of this intervention? I was very interested that also you came back and said, well, actually, if you're going to use anything, you'd use 3-TC or Nevirapine. But, tell us about that.
We just finished the 7-year follow-up of those kids enrolled in the trial, and compare them with the control group, and apparently those babies are progressing. Those babies, no, not babies. Those children are progressing extremely well. Sorry.
Temper tantrums, like the babies
yes.
losing their temper.
We had also a long-term evaluation of the potential harm of using antiretrovirals for their first year of life. And for example, evaluating the mitochondrial defect that we could observe. And very interestingly, this has not been published so far, but presented briefly at the CROI conference this year. Although there was a depletion during the first year of PrEP, this reversed completely to normal in long-term follow-up. So that means that the consequence, the long-term consequence of having those antiretroviral in the first year were probably very, very minimal.
Can I maybe respond to that as well from the ANRS results? Is that it was quite telling for me that it was only specific to the South African arm, but in South Africa, women in the lopinavir-ritonavir arm stopped breastfeeding significantly earlier than women in the lamivudine arm. And this, to me, my first guess would be these women didn't want to continue breastfeeding because they didn't want to continue giving Kaletra to their infants.
Yes, but you know, with the Kaletra, there was a huge problem with the palatability.
Yes,
and it was evident from the result that they were keen to interrupt lopinavir more rapidly than lamivudine.
So we give you each 1 minute. Amy, because you started, I think Philippe will start now.
Oh, okay.
So, and you will, so 1 minute exactly for each one of you, and then we will vote again.
Yes, my final word would be that infant PrEP is not competing at all with maternal ART initiation and option B+. It's purely complementary, and in my view, has a very important role to play in rescue strategies. When we know that a woman has non-suppressive treatment, we cannot leave the situation and without interacting. So I think infant PrEP is just a part of a package and not a sole solution per se.
We need to know a lot more about safety, and we really need to realize that this is an inseparable pair, the mother-infant dyad, and anything that's going to be effective for the infant needs to be effective and appropriate for the mother as well. We don't yet know, and we need the study that's going to show us that in addition to maternal ART, postnatal prophylaxis is going to add more. And I think actually if I just close with the words of probably the most astute and caring pediatric HIV clinician I know, Helena Rabi, that children are not continuing to become HIV infected because we are failing to give them infant PrEP. Children are continuing to become HIV infected because we are failing their mothers.
Those are really fantastic talks. So we're going to vote again. So for those who are for, please raise up your green. Okay. All right, let's do red. Those who are against. Okay. So those who were green and changed your mind. Who? Right, change it, it's green and then became red? Yes? Okay. Put up your red if you changed your mind. So went from we were pro, but now we're con. Okay, how many went from con and now we're pro? Okay.
There's one over there.
Great jobs to both of you. Congratulations.